Thank you, Umesh Khanna sir, for this invite and such a mammoth number of conferences which is being organized by sir in the last couple of weeks. And I sincerely thank Tushar sir for the wonderful beginning to the very big topic of chronic kidney disease. Can you see my slide?
Yes.
So without much further ado, I'll start my presentation. So the objectives of my talk today would be on transition into later stages of CKD. When do we refer to a specialist? How do we deal with the complications that come with the later parts of CKD? Access, preparation, and counseling, and at the end, renal replacement therapy. Uh, Beginning with one of our own patients, Mrs. V. She's a 30-year-old lady with no premorbidities, with no significant family history. In 2017, she had a spontaneous abortion, at which time she was diagnosed with a creatinine of 1.9 milligram per deciliter with a urine ACR of 350. We didn't have any more details about her urine analysis or her blood pressure measurements. She says that her BP was slightly higher at that time. In 2020, when she came to our center, she presented with a creatinine of 9.8 milligram per deciliter with all uremic symptoms. She had to be started on emergent dialysis with a temporary line, after which we created a left AV fistula, and she developed a line-related pseudomonas sepsis. This was all within a few days after she presented to us with end-stage kidney disease. Similarly, we had another patient, Mr. M, a 60-year-old male, a diabetic with retinopathy and proteinuria detected 7 years ago. He was on therapeutic doses of ARB. He had undergone a CABG for triple vessel disease, and he was stable with a creatinine of 1.5 to 1.7 milligram per deciliter. In 2019, his creatinine was slowly going up, and in early 2019, it was around 2.2 milligram per deciliter. And in June 2019, he was referred to nephrology. It was a gradually progressive kidney disease, but unfortunately, he was lost to follow-up due to the pandemic. September 2021, he presented with hypertensive pulmonary edema and a creatinine of 7 milligram per deciliter. Now, these are two patients with two different trajectories, which basically show us as to when do we actually refer to a specialist. We have KDIGO guidelines, which basically give us a broad framework as to when to refer. And one of the most important things is when there's an acute change or a sustained decline in kidney function. An albuminuria greater than 300 milligram per gram, or proteinuria, albuminuria of unknown cause, both of which that lady, Mrs. M.V. had, and hematuria associated with proteinuria, difficult to control high blood pressure, especially among younger people. It is imperative to check the renal functions and the urine analysis, and it provides a lot of information. Significant abnormalities of electrolytes, which is not explained by anything, recurrent or extensive nephrolithiasis, hereditary kidney disease. So as Tushar sir had already mentioned, when in doubt, refer. And I think the KDIGO as well as the risk stratification is fairly very clear. There are more refers than monitor. So whenever there is a sudden increase or people reach stage 3 CKD, I think it is very important to get a specialist referral and do the needful. Now, what happens when referral is delayed? There is more rapid progression of CKD. There's a worse health status at the time of initiation. There's a higher mortality after starting dialysis. There is decreased access to transplantation. And there is worse psychosocial, mental, and financial preparedness from this point of view of the patient. And the primary care physician plays an extremely important role in the smooth transition from the early stages to the later stages of CKD. So it's very important as a PCP to understand which is the at-risk population, which was beautifully enumerated by Sir. CKD stages 1 and 2 is where we try to prevent them from going to stages 3 and 5. But if they have unfortunately come to the stage 3 or stage 4, it is important to involve interdisciplinary care and also prepare them for dialysis as well as transplantation if possible. And I think communication and coordination is the key. And many of the times that is pretty much not present, especially since we have such a large population. It's very difficult for us to actually communicate with many of the general care practitioners who are actually treating the community and a large number of people at the community at that. So I think this cartoon basically gives us a very nice referral system where if there is a specific indication or there is a large risk group, or for example, polycystic kidney disease, it is important to get the nephrologist consultation quite early. If it is a diabetic with a rapidly progressive kidney disease, again, consult early. If it is somebody a stable like a chronic interstitial disease, it's good to kind of see them at least 1 or 2 years or at least 6 months. And if somebody is progressing after stage 3 or stage 4, it's important to communicate with the nephrologist and try to refer them and kind of review them with the specialist at least once to 3 months as required. I think India, as demonstrated by this graph, which I picked up from the BMJ Global Health, does have local CKD care programs which are implemented. But we need better and better access, and we also need more information to be given to the doctors who are treating all these patients at very many places. Now, dealing with complications. Now, coming to Mrs. V. So, she came with vomiting, itching, edema, and a pericardial rub. And Mr. M came with a breathing difficulty, orthopnea, and diffuse crepitations in the lungs. They had sky high blood pressures, very low hemoglobin. Mrs. V had hyperkalemia. Both were acidotic with metabolic acidosis. Both of them showed features of secondary hyperparathyroidism. The urine output was low in Mrs. V. It was good in Mr. M. Urine PCR was very high in both of them, and the echo showed like a uremic cardiomyopathy with a ejection fraction of 38% and a mild pericardial effusion and left ventricular hypertrophy. And Mr. M had a EF of 52% and he was post CABG. Now, late CKD, what are we dealing with? We are dealing with the symptoms: fluid overload, hypertension, diabetes, which can sometimes be totally uncontrolled, and sometimes patient may be having recurrent hypoglycemia, metabolic acidosis, hyperkalemia, bone mineral disorders, cardiovascular disease, a whole lot of polypharmacy because they have gone to multiple doctors by this time. Nutritionally, we don't know how much of counseling has been done. We are definitely dealing with the Google doctors and doctor shopping and native medications where people promise them, you pay me 8,000 rupees or 10,000 rupees and your CKD is going to get cured. And financial and mental preparedness is a real challenge, especially in a setup like ours, and multiple hospitalizations because of all the complications of late CKD. And we have to deal with conversations of renal replacement therapy, conservative versus aggressive care, dialysis, transplantation, or do we palliate this patient? I think to a large extent, we don't only go by numbers and we do look at the patient clinically before starting anybody on renal replacement therapy. One of the most important things is the uremic symptoms and signs, which can be very vast. We have a whole lot of uremic toxins and more toxins are being discovered. Your patient can have anemia, which can lead to all complications of anemia, platelet abnormalities, skin pigmentation, anorexia, nausea, vomiting. Females can have amenorrhea. Males can have erectile impotence. Infertility is one of the most important problems that people face. Often infertile couples, people fail to test their creatinine and urine analysis, and most of them end up having borderline CKD, which can actually lead to infertility. In later stages and more uremic symptoms, they can present with severe CNS manifestations, uremic pericarditis, as I elucidated in one of my own patients in this talk, hypertension, peripheral vascular disease, heart failure, renal wise. And many of our patients keep asking us, I am passing urine. Why do you say that my kidneys have failed? They can have nocturia, polyuria, salt and water retention, edema, and a whole lot of bone abnormalities, bone pain, hyperparathyroidism, and osteosclerosis. Anemia is one of the most important complications which we face at later stages of CKD. There are a lot of risk factors as well as reasons for anemia and CKD, and it is important to address all of them before somebody is put on things like erythropoietin. As I say, erythropoietin is only the cook, and we need all the other ingredients in order for the cook to actually make hemoglobin. So iron deficiency, blood loss, vitamin deficiencies, inflammation, hyperparathyroidism, nutritional deficiencies, etc., are very, very common in and all have to be addressed and tested for before we make a decision as to why the anemia is there. We have a whole lot of agents. We have iron, oral, IV preparations. We have also we have erythropoietin, which is of various timelines, short-acting, long-acting erythropoiesis agents, and soon we may have the hip stabilizers, where we will be getting oral agents to treat anemia in chronic kidney disease and dialysis. The other major important thing that we face is chronic kidney disease, mineral bone disease. I think it's a systemic disorder where we have abnormalities of calcium, phosphorus, PTH, and vitamin D metabolism. There are problems in the bone turnover, mineralization, volume, growth, and strength, and there is vascular or soft tissue calcification. So basically, we have targets set by KDIGO in stages 3, 4, and 5. We try to achieve them as much as possible. We have a whole range of medications like phosphate binders, calcium-based binders, non-calcium-based binders. And as much as possible, it is important not to unnecessarily load the patient with calcium, as it's clearly mentioned even the KDIGO guidelines, to avoid soft tissue and vascular calcification. Vitamin D again can be fairly low in CKD patients, and it's important to kind of test as well as treat. They are at higher risk for fractures, as well as the mortality is much higher in these set of patients. Hypertension is another difficult to control thing in chronic kidney disease. We often have severe resistant hypertension in many of these patients. And I think one of the most important cause of this is one, non-adherence, and the second being fluid overload. So it's important to individualize BP targets. I think sir already mentioned what our BP targets should be, around 130/80. We have recent 2021 guidelines to treat hypertension in CKD by the KDIGO. Tailor BP regimens in elderly patients with CKD. And all patients with CKD should be considered at high risk for cardiovascular disease, and there should be no prejudice in cardiovascular disease and heart failure just because someone has CKD. And we see that very often where patients are denied adequate cardiac care just because they have a higher level of creatinine. And in people with CKD and heart failure, any escalation of therapy, it is important to check the renal functions, especially the electrolytes. The cardiac markers like troponin and NT-proBNP have to be interpreted very carefully, and regular peripheral arterial checks. Peripheral arterial disease is the bane of especially diabetic CKD, and it's very important to have periodic assessments and podiatric assessments. And even peripheral vascular disease, especially with non-healing ulcers, can lead to fairly rapid progression of CKD. Metabolic acidosis is another common complications of advanced CKD, which is present in 30 to 50% of the individuals. So we try to keep the serum bicarbonate to at least 22 milliequivalents. Check the potassium because potassium can be fairly high. At the same time, try make sure that you're not overloading the patient with sodium, and keep a check on the blood pressure as well as the fluid overload symptoms. Hyperkalemia, another important factor which needs to be addressed. Serum potassium less than 5, provide information in order to avoid excessive dietary potassium intake. More than 5, try to check for any other causes, correct the metabolic acidosis. More than 5.5, down titrate or stop the anti-RAS medications. Dietary counseling, very important at all stages of CKD. Optimize diuretic therapy. Use K binders only if required. And I think more than 6.5, I think it's important to stop any RAS inhibition, perform an ECG just to make sure there is no cardiac involvement. And in cases of persistent high potassium, temporary measures and eventually dialytic therapy may be required. Nutrition is of utmost importance. The dietitian should be a part and parcel of every nephrology OP consult. They have to stage the CKD, assess the edema-free weight. There are many ways of doing that. Examine the fluid, salt, protein, vegetarian versus non-vegetarian food intake. Most of the people in the Indian setting do consume pure vegetarian diets, but even then, their salt intake can be very, very high. So it's important to restrict salt and try to give measures in order to avoid salt intake and make the food a little more interesting and more palatable. Initial dietary counseling is a must. You have to make sure, especially when we are giving low protein and very low protein diets, malnutrition can be a major issue, so that has to be looked into. So basically, goals of nutritional management should be slowing the CKD progression, controlling the uremia and proteinuria, and making sure that there is adequate dietary intake and optimal nutrition status.
Can we
Patient
summarize, Rajiva?
Yes, sir. So patient education is of another very important aspect where we have to involve the patient in all aspects, and it's important to communicate both with the PCP as well as us. Vaccinations, another important thing which is often missed, and presently don't even forget to vaccinate our patients against COVID-19. Access placements, there are various accesses, fistulas, grafts, catheters, and the peritoneal dialysis. And all this is dependent on various factors as shown in this particular cartoon. This KDOKI 2019 update, in which Dr. Tushar was a part of, shows us that it's very important to individualize access plans and also have a basic plan for a plan B and a plan C, whether it is transplant, post-transplant, access if required, post-transplant failure, what do we do then, and etc., etc. So it's very important to basically have a plan whenever we meet patients with CKD. And that can be influenced by various both dialysis influenced and non-dialysis influenced measures. Not all people require dialysis. It's important to discuss conservative care when required. And it's important to involve the family. And I think we had a very nice session on palliative care in the earlier session. There are two types of dialysis, both equally good, hemodialysis and peritoneal dialysis. This cartoon basically kind of tells us what exactly both the dialysis do. And HD versus PD, PD is more a sustained gentle fluid removal, ability to use cardiovascular measures, good in patients with significant cardiovascular disease.
Request Dr. Rajiva to conclude.
Yes, sir. So transplantation is one of the most important things that we should discuss with every patient, because it does give a dialysis-free life, better quality of life, better mortality benefit, less expensive than dialysis, and with better experience and drugs, there are better outcomes. So just to conclude, Mrs. V started her maintenance hemodialysis, and yesterday she got a kidney transplant and she's doing well. And Mr. M was admitted for IV diuretics. He was counseled for RRT and transplant, and we have put in a preemptive PD catheter and are waiting to start PD after break-in period. So CKD is a collective effort. These are some of the readings that I did in order to make this presentation, and a good guide for everybody. And I thank you very much for the patient listening.